poloxamer 188, which is a surfactant that decreases adhesion of the sickled cells to the endothelial wall. Exchange or simple transfusions are indicated for stroke or acute chest syndrome, but they're not indicated for routine pain crisis. Remember, in patients who get a lot of transfusions, you have to think about iron overload, and you may need to chelate them. Hydroxyurea is used for inpatients, and it increases the hemoglobin F level. It decreases the incidence of acute chest syndrome and the number of pain crises. And recently, like a couple of months ago, the 9-year data was published on patients who got hydroxyurea, and it suggested that there definitely was a decrease in mortality. So there is a mortality benefit of these patients being on hydroxyurea. Let's talk a little about acute chest syndrome, because I think that's one of the important things with sickle cell. The definition is a new infiltrate, fever, and respiratory symptoms. Again, it is exactly what you're going to see with pneumonia, and so you treat it similarly. The etiology is unclear. It may be a combination of vascular infarction, fat embolism, infection, hypoventilation, pulmonary edema. You treat with antibiotics, oxygen, inspectospirometry, control their pain, fluid management, transfusions. You can use simple transfusion or exchange transfusions. Again, simple transfusions, you're just giving blood. Exchange transfusion, you're taking blood out and giving blood, non-sickled blood. Especially if the hematocrit is towards the high end, like in the 28, 29 range, you definitely want to do exchange transfusions because you don't want their hematocrit to go too high, because that actually will increase viscosity and actually make the sickle crisis worse. And again, experimental therapies like nitric oxide inhalation and steroids. Paroxysmal nocturnal hemoglobinuria. The hemolysis is caused by an impaired synthesis of a membrane anchor protein at the stem cell level. This manifests as hemolytic anemia, venous thrombosis, Budd-Chiari sinus thrombosis, and deficient hematopoiesis. The hemoglobinuria can be present intermittently. So if you get a case of the patient who comes in and you may not get the hemoglobinuria, but they have kind of this atypical thrombosis like Budd-Chiari, which is thrombosis of the hepatic vein, or sinus thrombosis, or renal vein thrombosis, or something like that, and you see that they have a hemolytic anemia, think paroxysmal nocturnal hemoglobinuria. You may or may not, again, have the hemoglobinuria. A percentage of patients with aplastic anemia will develop PNH. You diagnose this by flow cytometry. Protein CD55, CD59 will be at low levels or be missing completely.
And that concludes this edition of Audio Digest in Medicine, a twice-monthly publication of the Audio Digest Foundation, a nonprofit affiliate of the California Medical Association. Our thanks to Dr. Sulkowski and Asher, and to the Johns Hopkins University School of Medicine for their cooperation in the production of this issue. This program is copyright 2003. Based in Blood, Hepatitis C, and Anemia on Audio Digest Internal Medicine, Volume 50, Issue 19, for the week of October 7th, 2003. Featuring selections from 2 Johns Hopkins University School of Medicine meetings, topics in clinical medicine, and internal medicine board review at Johns Hopkins. Beginning with Hepatitis C, Identification and Eradication, presented by Mark Sulkowski, Assistant Professor of Medicine, Johns Hopkins University School of Medicine, Baltimore.
First, I want to talk a little bit about the virus itself. One of the most important things over the past decade has been the recognition of hepatitis C as a viral pathogen. It is a flavivirus, a positive strand RNA. We've also begun to learn about its viral kinetics. Like HIV, this virus has a tremendous daily virion production, estimated about 1 trillion virions a day with a very short half-life. Picture a tremendous amount of viral turnover inside the liver and the serum. In addition, it has an RNA-dependent RNA polymerase. Now, the important thing with this enzyme is that it makes mistakes. It induces mutations or errors. The consequence is genetic diversity. Now, as we talk about treatment, we'll see that this already plays an important role in how human subjects respond to therapy. There are 6 major strains of hepatitis C spread throughout the world, known as genotypes. In the United States, genotype 1 predominates, affecting nearly 75% of those infected. Now, among African Americans living in the U.S., that number is nearly 95% with genotype 1. As we'll talk about, genotype 1 does not respond as well to current treatments. Genotype 2 and 3 make up the rest of the infection found in this country and is more responsive. Other countries, such as Egypt, have very high rates of genotype 4. So the genetic diversity plays a big role in how patients respond to treatment. Then within an individual patient, within weeks of infection, the virus mutates and can be found as what's known as a quasi-species, a swarm, if you will, of about 10 or 12 different variants. So this diversity almost certainly leads to chronicity as well as failure to respond to therapy. As I alluded to, this is truly a global problem. WHO estimates there are nearly 400 million persons living worldwide with hepatitis C. Now, in the U.S., this number is estimated to be around 5 million. But if you look at some parts of the world, such as Egypt, which I alluded to, it's estimated between 10 and 15 million people are infected, mostly through an attempt to eradicate schistosomiasis. Persons were infected as needles were reused in this attempt. But throughout the world, hepatitis C remains a very important pathogen. In the U.S., as we'll talk about, the epidemic is now entering its third and fourth decade, and the prevalence of liver disease as a result of hepatitis C is increasing. Now, in the United States, the data come primarily from a study called NHANES. This was a survey of Americans living outside of institutions, so it did not include prisoners or hospitalized patients. From this data, the estimates are 4 million chronically infected persons. There are differences according to ethnicity. Among African Americans, the rates were significantly higher than among Caucasians. So if you took one subset, that is African American men between the age of 30 and 60, the prevalence rate was as many as 1 in 10. If you take a city like Baltimore, where it's estimated about 600,000 people live here, although it shrinks every year, it's estimated as many as 1 in 10 people have hepatitis C, translating to a very major epidemic. When you compare some of these numbers in the United States, 4 to 5 million infected with hepatitis C, to HIV, HIV is certainly a very important disease and one that causes significant morbidity and mortality. But that number in the U.S. is about 1 million, so 4 times more prevalent than HIV. Now, in looking at how people get hepatitis C, I think it's important to acknowledge that although there are millions of people in the United States with prevalent disease, incident cases of hepatitis C have fallen. Current estimates from the CDC estimate about 30,000 new cases per year, and they are largely attributed to injection drug use. Now, unfortunately, injection drug use remains quite common in the United States, and in fact is increasing in some subsets of the population. Blood transfusion before July 1992 was a major source of infection. Now, in 92, there was the use of an effective antibody to screen the blood supply. More recently, nucleic acid testing has been used, and the current risk of a single unit of blood is less than 1 in a million for transmission of hepatitis C. It can still occur, but the risk is really quite low. So transfusion has fallen as a major source of infection. There's a large area of uncertainty. This, at least in part, because of how these questions are asked. People are given a questionnaire and asked if they have any risk factors for hepatitis C. And it's certainly hard to quantify things like injection drug use. But other risk factors have been discussed, but things like tattoo placement or intranasal cocaine use, although it's uncertain how many people are infected through that route. The CDC estimates as many as 15% of persons are infected through sexual transmission. However, there are many data that suggest that it's not very transmissible through this route. In fact, when you look among men who have sex with men or have long-term monogamous partners, hepatitis C transmission appears to be quite rare. So it's uncertain the role of sexual transmission. The CDC, in fact, recommends that discordant couples, where one is hepatitis C positive, the other hepatitis C negative, that condoms or barrier methods are not absolutely necessary. So on one hand, they attribute a number of cases to sexual transmission, but tell individual couples that this is an unlikely route of transmission. And again, this is at least in part due to our inability to tease out risk factors. Because couples share more than sex in many cases, there may be other unreported risk factors. So the epidemiology is primarily that of a blood-borne pathogen. And the primary cause of infection in the United States today is injection drug use. Now,